Good morning, everyone. This is Kathy Bush, and welcome to the DandleLION Medical Webinar on Breastfeeding the Medically Complex Infant. Many of our webinar attendees in the past have requested a webinar on breastfeeding, and we're so pleased today to have Kim Barbas with us to lead the webinar. Kim has been certified as a lactation consultant since 1994. She established the Lactation Support Program at Boston Children's Hospital in 1998, where she continues to facilitate breastfeeding under challenging medical situations and to promote breastfeeding education and support for families and staff. Her published research includes breastfeeding success among infants with congenital heart disease, and she presents at local and national level conferences on human lactation and medically complex infants. Her recent accomplishments include the innovative Mother's Milk Technician program she developed to establish safe, effective fortification of breast milk at Boston Children's Hospital. Welcome, Kim, and thank you so much for sharing your expertise with us this morning.
Thank you, Kathy. It's a pleasure to be here. For us, it's on the East Coast. We're halfway through our Friday, but good morning to those of you who are elsewhere. I'm happy to be here and share some of my experiences with the children that we serve. So, I'll start with a disclosure that I don't have any conflicts of interest. If there are products and things that I mentioned throughout this, it's not necessarily endorsing. It's just some of the things that we find work well with our population. Our objectives today are to recognize some of the barriers that hospitalized infants face in terms of establishing breastfeeding, to identify 3 techniques to facilitate breastfeeding in medically complex infants, and to look at a little bit of a creative approach to feeding those medically complex infants. We'll start with the healthy baby. And here's a nice picture of your new family with their first baby. They're all happy. Everybody looks beautiful. It's one of those, this is how people expect their experience to start out when they find out they're pregnant. This is what they're envisioning, is this beautiful baby laid on their chest, and they're happy. They're proud of themselves. When the baby is placed on mom's chest and she's able to latch and feed her baby, she feels that incredible power and satisfaction, that amazement that she created this being, and her baby is just beautiful to her. Most mothers aren't really thinking that they're not afraid for their baby. I mean, we all have that moment where we're looking over the baby. Are they breathing? Are they breathing? But that fear is more compounded in someone with a medically complex infant. Most average mothers, they're not worried about day-to-day danger for their infant, and they become more and more confident as a mother as they begin to breastfeed their baby and perform their daily cares. And they're identifying with other mothers. They're joining mothers groups and support groups to learn how to care for their baby in the best way possible. When you are delivering a sick child, a medically complex infant, this is often the first view that mothers see. They get a few seconds, if they're lucky, to sort of see the baby's face and be told whether it's a boy or girl before that baby's whisked off to a warmer to possibly even be resuscitated. And often mothers are very shocked by the appearance of their infant. If it's a visually disturbing defect, they may feel really guilty about how their emotions and how they feel when they see their child, and they're terrified. They are so afraid of what is going to happen to their baby. Is their baby going to die? Is something going to happen? Their anxiety levels are huge. Mothers really don't know what their role is. They watch all of these incredible professionals bustling around them who seem to know what every beep and every blip does, and they can handle this baby with wires and tubes without a flinch, and there isn't really much for them to do but stand there and watch, and they don't have as much confidence in themselves as a mother. Many times I receive infants from outside hospitals, and they're told that the mother may have been told at the hospital where she delivered that it wouldn't be possible for her to breastfeed because her baby has some particularly medical diagnosis. And they may be very frustrated or very disappointed because their birth plan included breastfeeding their baby for a year and living happily ever after. And they may feel really guilty. What did they do? They're feeling that there was something that they did to cause this to happen to their child, or that they failed somehow in their pregnancy. And they're very disappointed. And particularly I find mothers who may have breastfed before, who may have had a very successful breastfeeding relationship, they particularly know what they're missing. So they're feeling very sad at that separation from their infant. I think an important thing to remember with this population is that talking about breast milk and breastfeeding and that is the best source of nutrition for their infant is not a guilt issue. And this is a soapbox for me, and people know that don't get me going on that one, because guilt is a self-owned emotion. You know, we're not making mothers feel guilty. We're providing education to them. We're providing informed decision making, and mothers want to make the best decisions that they can for their babies, and they can't do that without being provided with all of the information at hand. And if then mothers are choosing not to breastfeed and they feel guilty about that, then that's their choice. That's not our issue. Oh, something just happened here. Okay. Paula Mayer is a nurse scientist at Rush Presbyterian Hospital. I don't know if anybody's out there from there, but she's one of my idols, one of my mentors to look up to in the field of human lactation. And I love the way she presents it. And at several conferences I've heard her say, human milk is an evidence-based health issue. It's not a gift, and it's not an art. This is the science. This is the science behind breast milk, and our babies, and particularly our sick babies, need this milk. And she has a great article about sharing the science. And what mothers found is it wasn't an issue of making them feel guilty. It was helping them to make that informed choice. And one of the ways you can phrase that, if you're working with a family that perhaps didn't anticipate that their baby was going to be sick, and perhaps they weren't going to breastfeed, but now it's a different scenario. Your milk is medicine for your baby. It's more than food, and we need that medicine to manage your baby's health care. So what's the big deal about breast milk? Well, most of you who are probably listening to this already know all of these things. I'm not trying to convert the choir anymore. We know the evidence is out there. If you've not familiarized yourself with the American Academy of Pediatrics policy statement that they issued in 2012, it's an excellent resource to support your practice. It has lots and lots of references, evidence-based references in terms of the benefits of breast milk. We look at the immune properties, the infection-fighting potential for gastrointestinal respiratory infections, ear infections, asthma, allergy, overweight, obesity. These are things that we've all heard about, and it's not the focus of today, but these benefits are even more important when you're looking at a child that's hospitalized and at risk for acquiring nosocomial infections. Benefits of breast milk, we find 64% reduction in gastrointestinal infections and a 72% reduction in upper respiratory infections for infants who are breastfed. And there definitely is dose-related response to that. Improved neurocognitive development. Necrotizing enterocolitis. This is another topic that is particularly important for NICU and hospitalized infants. NEC is a gastrointestinal disorder, very common infection that can occur in premature infants or infants who are at risk for ischemic bowel syndrome, cardiac or other diaphragmatic hernia, different procedures that are affecting the gastrointestinal system. And human milk has been found to be highly protective. The incidence of necrotizing colitis is more than 60% lower in infants who are fed an exclusively human milk diet. We don't have specific amounts that are necessary, but they feel that some of the studies have indicated they need about more than 50 mLs per kilo per day for that protective effect. And we want exclusivity. That's our goal now, is looking at exclusivity to provide the maximum effect from that benefit. The benefit of human milk for a hospitalized infant is in terms of sepsis, infection. Late onset sepsis, we're talking about occurring after the first week of life, something that's nosocomially acquired in our infants who are hospitalized. And once again, about 60% decreased incidence over formula-fed infants. The dose-related response, when we're looking at newborns, particularly in the NICU, if we can avoid fortifying in those first 14 days, I think that's a concern we very frequently are. Sorry, I just refreshed my browser, Kathy. Kathy, can you tell me how I would do that?
Kim, that was a different Kimberly that was having problems. You're fine. Just continue.
Okay, thank you. Sorry. Okay. So the benefits, and in terms of reduced sepsis in that first 14 days, obviously weight gain, protein intakes are things we're looking at fortifying early on. But if we can provide these infants with that colostrum without having, in that early transitional milk, without having a lot of additives, then that can increase their chances of survival at discharge. It decreases the risk of late onset sepsis, NEC, and death. And we're looking at about 100 mLs per kilo of human milk, decreasing that risk by 0.93 for sepsis. That's huge. Better feeding tolerance. Many children are, their recovery can be complicated with feeding intolerance. They have problems with gastroesophageal reflux because of all of the abdominal surgeries, cardiac surgeries that they're doing, and they tend to tolerate breast milk better. Their digestive system handles it better, and they can get to full enteral feed between 2 and 7 days sooner than with formula, and that translates to fewer days on parental nutrition, which ultimately is saving the hospital money, and babies are ready to go home sooner. Once again, that's saving hospital dollars. When you look at NEC, and some of these figures are actually from several years old now, Melissa Bartok's analyzation in 2010, a medical case of necrotizing enterocolitis can cost over $140,000. And if that baby perfs their intestine and has to go to surgery, we're looking closer to $300,000. Sepsis, $10,000. And then the cost of NEC can be up to $1,000 a day. So you're saving a lot of money by getting these babies on breast milk and avoiding these infections. We've pretty much covered this, talking about ease of digestion, the incidence of reflux. It's less irritating. Some of our kids that are having problems with aspiration, or you have a child maybe with a cleft lip, cleft palate, and they have more chance of regurgitating up through their nose and their nasal passages, breast milk is going to be less irritating for them and less risk of aspiration pneumonias if you're aspirating breast milk than if you're aspirating formula. Maternal attachment. This is an incredibly powerful thing for mothers. Very often I've been known to tell the mom, you know, this is your superpower. You are the only one that can make this milk for your baby. And there's often very long periods of time where they can't even hold the baby. The most access they have is maybe the palms of a hand or the soles of a foot that they can stroke. And this is something that can connect them and invest them in their baby. And that can have long-term lasting effects on their relationship. So that's a very powerful thing for them to provide. When they are able to hold their babies, the sensory stimulation of getting that skin-to-skin contact, being able to see their mother's face, to smell their mother, provides neurologic development to these kids who are hospitalized and spend lots of time in cribs. There's benefits, maternal health benefits. The increased lifetime lactation duration decreases the risk of type 2 diabetes. Mothers who never breastfed, or people who have never been breastfed, type 2 diabetes, it increases the risk by 40%. So we're looking at even just 1 to 6 months of breastfeeding is increasing that benefit. Women who develop gestational diabetes, if they breastfeed their child, they are provided with 86% decreased risk of progressing to a metabolic syndrome. Dr. Alison Stubbe, who works with some of these, she analyzed the nurses' health studies and published some of this literature. She spoke at one conference I attended and said that longer lactation decreases, talking about cardiovascular disease and risk factors, and she equated that to 30 minutes of vigorous activity in the gym per day. Personally, that, for me, I'd rather breastfeed longer than have to go to the gym every single day. And this is just some references in terms of those women's health benefits. So what are the barriers that our families face? Obviously, we recommend that babies go to breast in the first 50 minutes after birth, and especially within the first 4 hours. We know that baby's going to pass out and sleep for a long period of time, and that's the goal. Mothers are told, try to feed your baby right away. And these mothers can be weeks, days, or weeks, and sometimes months before that baby actually goes to breast. And when they are able to breastfeed, often even with premature infants, they'll be told you can breastfeed once a day, you can breastfeed twice a day. So the actual opportunities to go to breast are limited. Then there's the whole bottle feeding first situation. Nurses have been known, and I'm a nurse, I can take the blame as well. They want to be sure that the baby can eat. And so they'll provide a bottle to the infant before the baby goes to breast. There is no evidence-based practice for why a baby needs to have a bottle before a breast. And we really want these babies to be able to imprint. So we want them to go to breast first to learn the shape, the smell, the taste of their mother. And when they imprint on that bottle, they often have difficulty switching back and forth. Almost all of our children in a medical setting are going to have some bottles. But if that mother can have her baby to the breast first for some even recreational feeding, that can help them. And we run into the situation where they often have to be supplemented with formula or mother's not pumping enough milk. And we know that increased supplementation is going to decrease the length of breastfeeding. Diane Spatz from Children's Hospital of Philadelphia created a nice pathway to look at how to protect breastfeeding for the hospitalized infant, really looking at taking those histories and figuring out where they are in terms of, is that a baby able to feed at the breast? So if anywhere along the way in your assessment a baby is able to feed by mouth, and I think that that's an important thing, if that child can feed by mouth, there isn't any reason they can't go to the breast. They shouldn't have to have the bottle first. And if the baby cannot feed from the breast, then we need to get that mother to a pump and establish milk supply. And that needs to be done within 24 hours. So even some of your less severe presentations, the baby's not latching, within that first day, mom needs to get to a pump to protect her milk supply. So Diane's article on this pathway might be something that's helpful in some of your institutions to give guidance for your approach. Those of you who may be working in obstetrical situations. I'm getting an echo. Okay, thank you. So prenatal support, can you hear me okay?
Yes.
Okay. So prenatal support, in the obstetrical situation, we actually do prenatal consults through an advanced fetal care program here. Many of our mothers are receiving their diagnoses of a fetus with a congenital heart defect, an abdominal gastroschisis, some phalloceles, diaphragmatic hernias. Mothers very often know before they deliver that something is wrong with their babies. And so we connect with them in the prenatal period to talk with them about the advantages of breast milk. And many times mothers didn't realize that there's a difference between breast milk and formula. And this is a great time to talk to them about milk expression when they're not stressed with the new baby being there and worrying about where's the baby going next. Is there people looking to get consent for anesthesia or consent for surgery, and they're looking at their baby covered with tubes. So it's a great opportunity for us to look at what is their benefit for a breast pump. Most women will qualify with a medically complex infant for a breast pump, and talking a little bit about getting them started. And we find that this has really helped mothers by the time we meet them in postpartum setting, because we're not delivering the babies here. They've at least gotten started at the hospital, whereas in the past it would be 3, 4, 5 days the mother follows the baby here and the mother hasn't initiated effective pumping. So that's a good opportunity to talk to them about that and why their milk is so important. Surrounding the delivery, if you're in the perinatal period, if you know that this baby that's going to be delivered has a medically complex issue or is expected to have some kind of a problem, it's important to know what is the severity of that, because very often some of those situations won't preclude breastfeeding in the delivery room. We're not talking about gulping gallons of milk. We're talking about getting colostrum. We're talking about colonizing the intestine with a few drops, and we're talking about imprinting. This is her baby, getting some skin-to-skin contact early on so that we can initiate lactogenesis. Those are important things. And if she can't feed but the baby's stable, can she have some minutes of skin-to-skin with that baby? And if they are going to be separated immediately, that's an opportunity, if it's at all possible, to take a photograph of that baby before they get to the pediatric setting, because we do, the next time that mother sees them, that baby may have tubes all over its face, tubes in its arms, and that will give her at least one nice clean face photo that she can focus on when she's pumping and getting through the rough days ahead. So it's time to pump, time to get her going. Mothers should really initiate breast pump use within 2 to 4 hours of delivery. She should be pumping about every 2 to 4 hours. And generally, we want to state that more as a 6 or more times. Don't give her a definite number, but give her a minimum number. And many times people will suggest that they should be pumping 10 or 12 times a day, like a newborn would definitely breastfeed that often. However, that's not a very realistic goal for most pumping women. It's an exhausting process. They're often traveling back and forth from the maternity hospital or from home with other children if they're out of state or out of town, and it can be physically exhausting. So we look at generally 6 or more times in a 24-hour period. Talk about saving colostrum. We talk about this a lot in our prenatal visits because very often they're getting such small drops of colostrum, people throw it away. And we want to impress on them that this is valuable. And even if their baby is NPO and can't be eating, those small drops could be used for mouth care. In most of your institutions, I'm sure it is requirement that infants get mouth care every 3 or 4 hours, whatever your policy is. They may be using sterile water for that. You can substitute the colostrum. And if there's just a couple of drops, you could add some sterile water to that and use that to swab the baby's mouth. And that is something the parents can actually do as well with your supervision, is providing that. And then they're feeling like, wow, this is really important. These little drops, I'm going to pump to get some more. And that gets them going and motivated. Making sure that before that mom's discharged in a postpartum setting that she has a breast pump, either a rental or a portable pump, and providing her with the documentation she might need for insurance to obtain that if possible. Don't let her leave without a breast pump. We really, even though nothing is coming out in that first 48 hours of significant volume for most mothers, they need to know that the pump is stimulation to place the order to get their supply in. Hand expression. Jane Morton has done a lot of great work and has some videos at Lucille Packard Children's Hospitals, if anybody's here from there. But she has great videos on their website looking at hand expression and hands-on pumping techniques to increase the amount of stimulation that mothers are getting. Very often the breast pump does not remove the colostrum very well. Again, I tell mothers it's placing an order, that you're telling your body the baby's here, it's time to make milk. But doing hand expression and teaching them this and having them watch a video to learn some of those techniques. Moms just are not comfortable handling their breasts. They need to learn how to do that. But even if nothing came out with the pump, 5 minutes or so of hand expression might yield a teaspoon or several other additional drops that could be used for that mouth care. And what Jane Morton studies have found is that if mothers are doing this hand expression more than 5 times a day in those first 3 days, they had more milk at 2 weeks than mothers who didn't do this. And up to 50% more milk, I think, was the number that she used. And that can be very, very significant for mothers in stressful situations. So here are some of the links for Jane's work. And thank you, Jane, if you're out there. Next, whatever your hospital policies are, they need to know about proper storage and handling of their breast milk. Make sure that they're labeling it properly, whatever your particular policies are, dating it, etc., so that the right baby is getting the right milk. Reassure them that milk onset is gradual, that they may not get very much in that first 48 hours, and then between day 3, 4, 5, maybe a little bit later for C-sections, they should be noticing a gradual increase. Anticipating engorgement phase is very important. Many of these mothers have had complicated births. They've gotten a lot of IV fluid. Their engorgement may be extreme. They have extreme swelling in their breasts, sometimes up to their clavicles. They're hard as a rock, and they wonder that, am I going to be this way for the entire time that I'm breastfeeding? And letting them know that, really, truly, engorgement is a pathological state, but call it normal fullness. This is what we expect to happen sometime over, the 4th or 5th day. Your breasts are going to swell, and I love to, preempt that on a Friday. If you're meeting a mom who's day 2 or 3 on Friday and no one's around to help her on the weekend, let her know. This is what's going to happen. It's going to last for about 48 hours, and by Monday, you're going to be a new woman. It really can be handled much like swelling for a swollen ankle. Put some ice, some cold packs on it. That's what we're trying to do, is decrease the edema that she's experiencing in her breasts. And we talk about doing areolar compression, or what's called reverse pressure softening. And this technique was labeled by Jean Cotterman, who I just heard passed away this week, and she was definitely one of our pioneers in the lactation world. So rest in peace, Jean, and thank you for your work. This is a technique that she put a name to trigger that nip ejection. When you have an edematous breast, if you can see the woman's fingers here, you can see she's really putting dents right into that breast. She's got basically pitting edema and putting fingerprints around the nipple. This is the nipple here. By pressing in and holding, you're pushing that swelling back into the chest, and it's reducing some of that resistance so that the baby, or in this case the pump, can actually effectively remove milk. So it can be done with this 5-finger sort of a pedaled approach, or it can be done with a 2-fingered approach. And then the description of how that's done is here in your slides. And basically you're going to press and hold for several seconds and rotate your fingers around the breast, and take a couple of minutes, even up to 5 minutes, to soften the areola And then that way, even though the breast remains hard and edematous, the nipple itself, you're not going to have that resistance on the pump. You're not going to cause damage with the pump. And if the baby's actually feeding, the baby could latch. And this is a great technique. We've often taught this with mothers with well babies. You can talk to them over the phone on how to do this if they're at home with this engorged breast, their milk is coming in, and they don't have a pump. This is one way to help facilitate latching that infant. Early, frequent milk removal is really important to protecting their volume. Sometimes mothers think, well, if I wait 4 or 5 hours, I got more milk. But if they continue to do that over a couple of days, the body's going to say, oh, we don't need as much milk, so we're going to decrease production. So it's the empty breast or the well-drained breast that's going to stimulate milk production. So they need regular, frequent milk removal in order to do that. We do provide a pumping log to many of our mothers. There's also some great apps that you can get for smartphones, if they're smartphone users, that they even can set an alarm on that to remind them when to pump. They can keep track of their pumping volumes. And we find that very helpful for the lactation consultant, or the nurse can review with the mom. She says, yeah, I'm pumping. You know, that's not a very open-ended question. You want to know, how often did you pump? Did you pump more than 4 times, 5 times, or 6 times in the last 24 hours? How much volume did you get at each session, and what does it look like at the end of 24 hours? And then we can intervene if they're having problems with their supply before it gets serious. So what are our volume goals? Every mother is different. You're going to see differences in volume, so we can't tell her exactly how much she should be making. But in general, by the second week, and they say by day 5, but it's rare that I see mothers by day 5 having 500 ml a day when they're pumping. But we would love to see most mothers in the 16 to 20 ounce range. Anything over 20, 25 ounces is going to be great. And if they're less than 12 ounces or less than 350 mLs in a 24-hour period, they're really in that borderline low production phase, and that's going to be difficult. We should really intervene at that point to increase their supply. And actually things, I don't know if I included much about talking about increasing milk supply, but obviously the first thing is going to be pumping more often. We can look at mom's nutrition status, increasing protein, galactagogues. Many women like to try things like fenugreek or Galacta or other kind of nutrition type supplements. But the most important thing I think that you have to impress upon mothers is they have to use the pump. I can't give them a magic pill to make them make milk. They have to remove milk. Maternal recovery is a very important piece for these mothers. We have, a delivery hospital nearby, so it's actually connected by a bridge, women's. And so a lot of these mothers are coming over by wheelchair, but if they're coming from other hospitals, they may have taken early discharge, or they're really up on their feet way more than they should be. They're out of bed when they should be home, laying with their babies and just breastfeeding. So I think that keeping that in mind, that the distance they're traveling, they need to use wheelchairs, they need to manage their pain, they have to take their pain meds, they can't be martyrs about it, and allow time for them to rest and their wounds to heal. We do see quite a few moms that end up with UTIs or C-sections that dehisce because they're just doing too much, and mastitis. So we need to pay attention to that as well. Very often, the focus is so completely on the baby that the mothers are lost in that shuffle. So it's time to start breastfeeding. Whenever it's possible for that baby to eat by mouth, we want to initiate breastfeeding first. This is going to help the babies, really, we want to focus on this is a new baby. So however you're handling that baby, you really want to model that. Talking to the baby, I find it's incredible when, you set a baby up with the mom in her arms to breastfeed and the mom gets completely silent, especially my families that are from other countries or speaking other languages as their primary language at home. That's a very familiar sound to that baby. My voice is different, and I love it to see the response on the baby's face when I say, speak to the baby in the language that you speak at home, because they already are recognizing that, and helping them to realize that this baby knows them as their mother is really valuable, and helping them to separate that, this isn't a Down syndrome kid. This is a baby who happens to have Down syndrome. And this is still a new baby who has the same needs to be held and fed and cuddled and talked to as other babies. Identify them by their name, not by their defect. I've already talked about breast before bottle being very significant, so that even if we just put them to breast. If they're very concerned, sometimes depending on the diagnosis, it may be that they're only allowing very small volumes, 5 cc's, 10 cc's, and they're gradually increasing. So we may give them small volumes by bottle initially, and then once they hit about 15 to 30 cc's, then they should definitely be able to go to breast. But we could also have moms pump first, and then when the breast is well drained, they can do what we call recreational breastfeeding. Let them put the baby to breast, let them look at mom, taste some milk. If they don't latch, big deal. If they actually smile at the breast and taste a little bit, then that's a positive result. I very often get called and say, well, mom tried to breastfeed last night, but it didn't work. And that becomes a negative first experience. We just want them to get comfortable doing some positioning at first, whether the baby latches or not. The baby becomes familiar, helping mom to learn how to squeeze her milk out so there's something for the baby to taste. Volume for the first feedings should not be the goal. Oftentimes these babies have nasogastric tubes still in, or G tubes, and they're going to be receiving the volume that they need and the extra calories by that. So this is really a time for mom and baby to get to know each other. They probably have limited opportunities to even hold their baby. So providing their supplements by the NG tube is one of the ways that you can initiate breastfeeding without having to use lots of bottle feeds. So once the baby starts to be latching well and seeming to swallow milk and transferring milk at the breast, that's when we can start to back off a little bit on the NG tube. So watch the feeding. You can't put a baby on the breast and walk away. You have to observe what's happening and see the swallowing and do an assessment and see if the baby is starting to do that, then maybe we give half of the feeding by NG. You can back down a little bit at a time, and then perhaps you can do a 24-hour trial of POs, just taking all their feeds by mouth and see what their eyes and nose look like at the end of the day, and then you can pull the feeding tube. So that's our thing, creative feeding plans. I think one of the things that people will say is mom can only breastfeed twice a day or 4 times a day, or every other feed seems to be a very common thing as we're making that transition. But every other feed doesn't have to be very specifically, every other feed. If mom's only able to visit during, the 8 or 10 hours that her kids are off at school, then she should breastfeed during that period of time. And then the nursing staff can provide bottles at night. So it doesn't have to be specifically. It can be a clump of time, 8, 10, 12 hours. That's their breastfeeding time when mom is available. What's our goal? Our goal is to promote slow, steady gain while they continue to receive their supplements. I think that's an important piece. We would love all of these babies to be exclusively breastfed. However, their caloric needs often exceed what they're able to take in at the breast. So they're going to be getting daily weights. I think that parents end up focusing way too much on that. They need a reminder that the weight is not necessarily reflective of growth at that point. We need to look more over time at the end of the week. But their daily weights are also reflecting fluid balance for kids that are getting diuretics, cardiacs that are infants that are recovering. So we want to see that 25 to 30 grams a day weight gain over time, but we also are trying to balance that out with the fluid balance. So they need to have the breast milk fortified. For some of these kids they'll have a lot of catch-up growth. And if we can maximize the amount of calories that we're putting and then do less volume of that, then that's going to allow the mother to do more breastfeed. So if, for example, the recommendation is to have 26 calorie per ounce feedings all of the time, could we go to 28 or 30 calories and give half of that volume by bottle and allow mom to breastfeed the other 4 feedings of the day? So that's what I talk about. You're going to maximize the calories in the small amount of volume. And if the baby's doing well at the breast, can she just do, 8 ounces a day of this high calorie supplement? Maybe she does 1 ounce at the end of each feeding. If mother has a sufficient volume, we can consider what we call hind milk feedings and pumping. Hind milk is the milk that comes later in the feeding. It's higher in fat and calories. If you've had the opportunity to see this, the hematocrit method can test the fat content and calorie content in the breast milk and give you an idea of where mom is at. And if mothers they need to have a sufficient volume, maybe about 30% more breast milk volume than the baby is taking out of feed. So a baby needs 2 ounces and mom is pumping 3 or 4 from a breast or 3 from each breast. She could pump off the first ounce. It's about a 1/3, 2/3 ratio for milk and high milk. And now the baby is going to receive higher calories directly from the breast. So that's one way that we can increase the fat content of their feeding when they're at the breast, as opposed to the fortifying in the bottles. As the baby's starting to progress in their breastfeedings, I don't like to do this for first feedings. And sometimes, you know, with surgeons, they want numbers. They want to know exactly how much is going in and coming out. But I don't think that this is fair to do to mothers on the first couple of feedings. So I'd like them to get some association time with their baby, start to learn their positioning. But then if a baby is starting to look good at the breast and is transferring milk and swallowing, then we can initiate test weights. And the procedure for that is to weigh the baby before and after a breastfeed. And this can be used if it translates the grams of intake that a baby reflects on the scale, translates to the milliliters of volume that the baby drank. So it's important that you do that accurately, and sometimes that helps for staff confidence as well. If you're not great at assessing breastfeeding, or you need to have numbers for your flow sheets for your I's and O's, for your fluid balance, then this can help. And it helps mom's confidence. So mom feeds the baby gets weighed first with their clothing on. They don't need to be stripped down. We don't want to change diapers in the middle, but the baby gets weighed, the mother breastfeeds, the baby gets weighed again immediately after. No changes, keep the hats, the socks, all of those things. And we subtract the pre-weight from the post-weight. And that can help moms to realize if they think the baby's not getting anything and they see that volume on the scale. And maybe they want the baby to have 30 and the baby's taken 25. Well, put the baby back on, take 5 more cc's. But if the baby can only take 15 and they need to have 60, then that can tell us we need to put that extra 45 through the feeding tube, or perhaps offer it by bottle. And what about mom and her adjustment in terms of moving to breastfeeding? Fortunately, a lot of hospitals are moving to a lot of single rooms, but they may not have their own room. Even if they have their own room, people walk in and out all of the time. They're emptying the needle bins, the trash, they're mopping the floor, they're doing all kinds of things. And so they don't have much privacy. And some women are not going to be comfortable bearing their breasts with people walking in and out. So provide them with a privacy sign that they can put on the door. We have one like this that just says, please knock, although I swear it says walk right in, because people don't often listen to it. But this at least gives them a sense to say, hey, look, slow down. This mom may be using her breast pump, or she may be nursing her baby. Making some accommodations for her all the wires and her positioning. They need some pillows for support. They need footstools so they can get their lap up and sit comfortably in a chair. And if it's at all possible, this baby has a baby with a congenital heart defect, but this baby can be off of the monitor while the mother is feeding. If you can disconnect some of those wires and lines so that things aren't beeping and making all of these distracting noises, that's going to help mom to feel more comfortable. A lot of times people say, well, I want to run the tube feeding while the baby's at the breast, so they get this sensation of a full belly. But really that just adds one more complicating line when you're trying to position and move the baby around. So I recommend that you wait until after the feeding. Teach her to relax. We've hopefully already taught her how to do some hand expression, but definitely doing that massage and breast compression and stimulating her breast to have her milk letting down or leaking before she brings the baby to the breast is going to help the baby to have something to smell and to taste. And as you can see here, we recommend supporting the breast or supporting the baby with the pillows. That's an important thing for babies who may have low muscle tone or are weak, recovering from surgery. You have a very large, heavy breast that's bigger than the baby's head. They can't support their face at the breast. They need to have that weight lifted. And in some positions, if you have them perhaps in a clutch holder, commonly known as a football hold, the weight of that breast could easily be sitting right on that baby's chest. And you wonder why the baby's not sucking. They've got 15 pounds sitting on them. And so you need to lift and support with the hand the weight of the breast so that the baby can focus just on latching. As far as positioning, I'd like to say that there's no rules. All ideas are fair game. A lot of times people will say, I'm doing it wrong, and there isn't any specifics. We have suggested positions, and there are many things in books that will label the name of a position, for example, but what there's some current literature out looking at biological nurturing and looking at this semi-reclined position of just lay back and put the baby on the breast, and the baby can literally, find their way to the breast, and their gravity is going to help to have that baby latch. But we don't have the luxury necessarily of having reclined lovely beds for mothers to be in. So, for example, in this situation, this baby had a bladder extrophy and was being put in traction, in 90-degree traction for 3 weeks, the first 3 weeks of life. Now, I'm happy to report our processes have changed, and these babies are going home and having surgery later, which is lovely because they're now able to initiate and have breastfeeding well established before they have surgery. Whereas in this situation, many mothers were not able to breastfeed their babies until about 3 weeks postpartum, until I said, well, why can't we get the mom in the bed? So we climb mom right up in the bed, and yes, the baby's cranking their head to the side, baby not ideal positioning, but at least it's getting mom and baby together, and they're able to initiate breastfeeding and start that sooner than waiting the 3 weeks. So any positioning that works. We have many situations where procedures, the infant may have perhaps spina bifida surgery. The baby's laying prone, they're on a pillow. That baby can still, again, turn their head to the side. You can take the whole baby on the pillow and put them in mom's lap and at least try and get them in proximity, mouth and nipple, so they can do some recreation while they're waiting for their recovery period to end, when they can actually be more mobile. Positioning the baby sort of slightly above or below the breast, that can help in terms of babies that are having difficulty handling the flow. So, for example, an infant with a wide open cleft lip and palate. Now, granted, many of these kids are not going to be able to take in all of their nutrition if they have a complete cleft lip and palate, because they can't form a seal. They're not able to remove enough adequate calories on their own, but they can still do some practice at the breast. But you may want them in a more upright position, and you're going to want the direction of the flow to be changed more towards the lower back of their throat, not towards the opening in the cleft, or they're going to aspirate and have difficulty. Some mothers have very rapid milk flow as it is, and in that situation, it's the same thing. Utilize gravity in their favor. Have that baby be more upright with the head slightly higher than the breast. Have mom scrunch her hips forward and lean back so that the baby is actually coming on top of the breast, and they're able to use that gravity in their favor. The milk isn't going to be shooting down their throat. And watching that suck, swallow, breathe coordination. I think that's an important thing to realize, is that at the breast, the baby is able to control the pace of the feeding much better than on the bottle. Once suckling, suction and flow is initiated on a bottle, that milk is going to keep flowing through that nipple. And very often the baby is going to take their tongue and press their tongue against the end of the nipple to stop the flow of milk in order to take a breath. And that's why we see on oxygen saturations in babies that are bottle feeding, we see these subtle little breath holding episodes where they're actually taking a break so that they can breathe before they initiate the flow of milk again. When they're breastfeeding, that the difference is that they're able to determine when to make that milk flow, and you see much more stable oxygen saturation patterns, and their oxygen saturations actually do go up during breastfeeds compared to saturations on babies with a bottle. So in this position, you can see this mother's got a little bit more of a hold on this baby's head than I would encourage, but it is allowing her to support this infant in an upright position. You've got a nasogastric tube. Sometimes you've got oxygen here, so they often feel like in other positions that the baby's nose is being occluded. So in this clutch hold, it's allowing the baby's nose to be free. They should have a little bit of an asymmetrical latch, getting that chin in nice and deep. But what you can't really see in this view here is, see this mom's first finger? So many babies don't have a lot of strength and tone in their jaw and in their mouth. If they're recovering from surgery, they may be a little weaker. Mom's holding the breast with the bottom 4 fingers, the thumb on the top. Take this first finger and just slide it over to the baby's chin. And that's going to allow a little bit of that first knuckle and first finger to apply gentle pressure to the baby's chin. So when he does latch and form a seal, they can help them to hold that seal and sustain their latch more effectively. You can see here this little guy's determined to pull his feeding tube out. They're very good at that. Somehow that's how I get to do a breastfeeding challenge, is just let them have at that tube and pull it out. So that's what we call a modified clutch, or the football hold. So they're a little bit more upright. It's allowing them a little more ability to control the flow and not choke. Modified transitional hold, that's when you've got the baby in the, I'm going to go back this way a minute here to this mom. Where'd she go? This mom. So when we call a typical Madonna hold or cross cradle hold, mom's arm is coming around this way. Transitional hold, we've switched hands so that this mother's arm is coming right up the baby's back. You've got ear, shoulder, hip in nice straight alignment. And she's able to support her breast on this side and guide the baby's body and head and shoulders into the breast on this side, rather than having the baby's head in the crook of her arm. And sometimes that's just a little bit easier for them to visualize when you have a baby that doesn't know where they're going for those initial feedings. So we want to support the latch, not grab the back of the head. As I said in this other hold, this mom's a little bit on the head. Really, their hands should be at the base of the shoulders, and the first finger and thumb are cradling the base of the baby's head to bring them in. Babies do not like to have their heads shoved into the breast. And we want just a steady, gentle pressure towards the breast. And that's going to allow them to drop their jaw and open their mouth wider to draw more of the areola in. And as you mentioned, supporting those heavy breaths so that they're not going to be exhausted from holding it. This is an old picture. I was trying to find a more updated one, but Sarah Danner and Edward Cerruti applied this name, the Dan-Sir hold. And essentially, she's taken that step one further from the mom who is holding the first finger is supporting the chin to sliding. Now she's slid the thumb off of the breast and used the thumb and the first finger to support both cheeks. And so basically they're able to decrease the intraoral space using mom's hand so that the baby, it's really what it is under there. I'm trying to think if I can describe this without, I usually have a little model. You've got the ability to sort of cup the baby's chin between the pinky and the thumb and provide pressure and support on the chin, and then the other fingers way under here are supporting the breast. And that way, if you've got a baby with with decreased fat pads, or tiny babies that are learning to sustain their latch, you can increase the intraoral pressure so that they can remove the milk more effectively. And that's the dancer hold. Babies that may have an uncoordinated suck. Oh, I think I have to hurry along here. You're going to use the pacifiers for non-nutritive suckling. We may use Nipple Shields, some of our alternative feeding methods. I'm going to go through these a little bit. Nipple Shields were out of favor years ago, but I think it's important to realize there is evidence that supports the use of a nipple shield to help a baby sustain latch. And so the nipple shield is like a little Mexican hat. And what this is doing is extending a mother's nipple deeper into the baby's mouth when they may not have the energy to sustain the latch, or perhaps usually they're originally for anatomical reasons, short, flat, or inverted nipples. But in cases of babies who are medically complex or weak premature infants, what you're doing is you're allowing that baby to be on the breast and to suckle a couple times. It's going to allow the milk to drip into that nipple shield. And so if they need to take a break and rest, when they start over again, that milk is there, the nipple is still there. Because preterm infants or sick babies spend a lot of time latching on and latching off and falling off, latching on and falling off, and then they're exhausted. And this is going to help them to organize that a little bit by getting that automatic response each time that they suckle. And Paula Mayer's work with Nipple Shields did show that these babies actually drank more milk from the breast. When you're looking at small preterm infants and you're talking cc's, any increased volume is important to help them. And they did that more with the shield in place than without. And I think for some babies, it gets the baby on the breast, and it gets that mother feeling like she's a breastfeeding mother. That's the transition from the bottle into to the breast. So important to know, though, they're not going to fix breastfeeding problems like sore nipples or low milk supply, and you do have to have that used with instruction of a lactation consultant. And they should be followed with weight checks to make sure that mom, is using it properly and that the baby's removing the milk effectively and she's maintaining her milk production. As far as alternative feeding methods, bottles, this is a picture of the special needs feeder. It used to be called the Haberman feeder, and this is being used with a baby with cleft palate. cleft lip, I'm sorry. So the purpose of that is the gradual flow and the ability to reduce flow. Another type of cleft palate feeder is a pigeon nipple. The actual hole in the nipple looks kind of like the little footprint a pigeon makes. The thing about nipple choice is our feeding team is very supports using a bottle that has a slow flow, something that's soft and pliable like a breast, a silicone material, something that's perhaps a wider base. The idea is that it should have a gradual angle from the tip of the nipple to the base to promote that baby flanging their lips and looking on the bottle the way they would look on the mother's breast. When we're supplementing with bottles, a lot of times people are worried about nipple confusion. It's overrated. It's not nipple confusion. I like to call it nipple preference. And the big deal is that babies know. They learn. They know what they like. They're not stupid. And they are choosing that big, long bottle nipple. And so that's one of the reasons, if they're not ready to be flexible and go back and forth from breast to bottle, that's what people are concerned about in your healthy population. But if we don't necessarily have that option when babies are medically complex. So they may be doing we always say, well, try at the breast and then give them the bottle. But the problem is that they often are too tired after that length of time at the breast. So starting with the bottle, giving them some of the volume that they need, and then finishing the feeding on the breast when it's more leisurely, the baby's not freaking out and hungry and screaming, is often going to be a more effective method for these mothers as they're transitioning off of the bottle and on the breast. And that sort of finished at the breast method comes from Christina Smiley, and there's an excerpt of that link from Diana West and Lisa Marasco. Supplemental nursing systems. Here you see a do-it-yourself kind of method with a syringe and a feeding tube, and here are some more specific lactation aids that are made by different companies. And essentially what this is doing, you've got a baby that's able to suckle well at the breast and latch, and this is providing, if mom has insufficient milk, this can provide higher calorie formula. Or if the baby just needs to have high calorie volume, we can put fortified breast milk in here to give the extra calories that the baby needs, and the baby is drawing that in with the breast. Some other considerations: decrease your environmental stimuli. Don't call the lactation consultant for a feed and then say, well, I'm just going to check the blood sugar, teach mom how to do a tap, do some vital signs, and wrap them all back up, because now the baby's exhausted. So I'd rather you let me do all of our stuff and have the baby feed when they're ready than take another 20 minutes of those things. We talked about redefining what breastfeeding success is. If the baby licks, and tries to latch, then that's great. Our first goal is really to protect the milk supply, to get that milk being fed to the baby, and then to be introducing some breastfeeding steps and having short, frequent learning sessions and opportunities for them to rest and to practice it, and teaching those families how to recognize the quality of the feed is much more important. Not all of the breastfeeding is going to happen during the time that they're at the hospital, and most of these mothers are going to progress to increase frequency of breastfeeding once they're home. Consider donor milk. If you don't have a donor milk policy in your hospital, you should. Donor milk should be used. Our policy is like many others around for preterm infants who are less than 1,500 grams or less than 32 weeks gestation, and we are using it in our cardiac population here for infants who are at risk for ischemic bowel, and we want to maintain exclusive breast milk feeds before they go to surgery, or our rescue babies who are coming with neck that need to be resuscitated intestinal-wise. We're going to start with breast milk, with donor milk, if mom doesn't have enough. Bridge milk is a term that we use. This is for example, our infants with congenital heart defects may have a few days before they go to surgery, and the docs want them to have some nutrition, but mom's milk, we talked about how difficult it is to pump in those first few days, and she doesn't have a huge volume. That's an opportunity to provide donor milk in addition to whatever mom pumps, so that that baby stays exclusively breast milk fed before surgery. Baby has surgery, mom's got a few days to catch up while the baby's not feeding and is on the ventilator, and then by the time the baby is ready to eat again, mom has a stock of milk, and we're able to get them off of that. And it's very low cost because you're talking a small volume in a finite period of time. And you need to consider storage space. I hope some of you have freezers like ours that we constantly are running out of space for some of these moms who are pumping long term. So you have to consider having a backup place for moms to store milk, and moms need to purchase freezers for use at home. And working with this population, of course, unfortunately, we do encounter the situation where an infant does not survive, and all of your your grief counseling and weaning measures are going to be pertinent. Many times, I'm sure others have experienced also, we have the ability to anticipate this if care is going to be redirected, and if you've established a relationship with a mom as a lactation person or as a nurse, it's something that could be addressed before the baby's care is redirected and before the baby passes away. So you can provide some information about comfort measures, how to wean her milk supply, and give that in written information, and discuss a little bit about the milk donation process so that mom can think about it and have that sort of out of the way before the death of the baby. And so that's the end of my talk. What do you think? We have some questions, I think, popping up.
Kim, that was absolutely fabulous. Thank you so much. It was really, really rich with information. If you will all look on the left-hand side of your screen in the chat area, you can type your questions there, and we will feed them to Kim, and she will answer as many as she can in a given time.
Okay, so where should I start, Kathy?
So this is Kathy Randall. I'll help to field a couple of the questions for you. And by the way, Kim, that was so good. There were so many little pearls of wisdom that it was really good. I really enjoyed it.
Thank you very much.
So there was a question from Catherine Robbins from Cardinal Glennon about volume goals. And I asked her if Catherine, if you're still on the phone, if you could clarify what section you were referring to about those volume goals. I think she was wanting to know whether or not they were for preterm babies, term babies, or both. So I don't know if you know exactly what she's talking about.
Okay, yes. I think in terms of pumping volumes may have been what she was referring to.
Okay.
Many mothers of preterm infants do have smaller volumes early on, and I think any volumes that they're getting, it's very reassuring. If mom's like, I'm only getting 15 cc's of milk, and her baby's, and you say, but look, your baby's getting, 1 cc an hour, 15 cc's is providing almost an entire day's worth. So that keeping that in perspective for mothers when they're not making huge volumes, that they may be making exactly what their baby needs at that time. Those volumes are more, the volumes that I refer to is the many things, sources that you read suggest that mothers should be producing 500 cc's by the 5th day. I think that's for your actively breastfeeding baby, and when you're pumping, it's very difficult for mothers to meet those goals. But I do know that is a recommended volume. We do want moms to be pumping enough to get really upwards of 500 cc's a day after day 5 or into the 2nd week.
Excellent. Just one quick note, people are asking if there's going to be recording. We always record the webinars, and we'll post that later. So for those of you who had to go off and do a delivery, you'll definitely be able to get that. There's a question, and it may be beyond the scope of the time we have, about just, if you have any particular philosophy about infants of moms with substance abuse problems or who are in methadone programs, if you have a strategy for that.
So methadone is considered to be compatible with breastfeeding. Mothers are able to provide breast milk to their babies when they're in methadone treatment. I like to refer to the Academy of Breastfeeding Medicine's protocol for mothers who have substance abuse problems. They have I'm trying to think of the exact title of that protocol, but if you go to the Academy for Breastfeeding Medicine ABM website, you can get that protocol. And that's what we refer to. It kind of gives some guidelines for when mothers tested positive, what kind of treatment programs they're in, and when you can or can't use the milk. Great. That would be my recommendation.
Really quickly, what is Cabo cream? We had several people asking about that.
Yeah. Oh, Cabo cream is a cucumber cabbage-like extract lotion. It's made by a company. It's called Cabo Cream. I believe the website is even cabocream.com. You can Google it. But it's a lotion that was designed, I believe, by a nurse lactation consultant. And I'm sure many of you have heard of using cabbage leaves for swelling, because cold cabbage leaves will decrease the inflammation, and people will put them on the breast. And so they took that the next step further and designed a lotion that can be applied to engorged breasts to decrease swelling. The caution for that is that, lotion, it smells nice, it's soft and feels comfortable, but we don't want to be slathering the entire breast frequently. I've had a mom that definitely dropped her milk production by doing that. So we do have it available, and we give these little small packets of it to mothers in the event of an infant loss, because it does expedite the weaning process. It seems to dry up their milk faster. So when they're cutting back on their pumping and they're very uncomfortable, they can apply that several times a day for a couple of days, and it does facilitate that.
Awesome. Kathy Bush, how are we doing on time? We have obviously a few more questions.
Yep, I keep going. You can ask a few more.
Okay. So I'm going to maybe pick one here. Saying, what about babies with short bowel or other anomalies?
Well, actually, I think I was referring to all of those babies in my talk today, because whenever I say, gut babies or GI anomalies, that's what I'm talking about. We have many babies that have had, a perforation of neck somewhere else that come here, and then, in the surgical process end up in the short bowel programs. We have a lot of abdominal wall defects. I would treat them, we treat them the same way. Obviously, the kids are on parenteral nutrition for a very long time, many of them. So maintaining mom's milk production and having a place to store her milk until this baby is actually able to start receiving her milk. And then they start getting small volumes, and we enhance calories, and they do. We transition them to breast as soon as we're able to. It just can sometimes be a really long time.
Yeah.
But it's the same thing. Yep.
All the same philosophies.
Yes.
There's a question from Chris Auer that's saying, for preterm infants in the last week or so before discharge, what is a way to breastfeed and assure volumes? And that she's referring to Paula Meyer suggests the baby has a target for 12 hours and then you adjust supplementation. And the question is it's never been clear to me if it means only add supplements at each 12-hour markers, or do you have any comments about using that philosophy?
Yes. So I guess, each individual, I know that many NICUs will only allow them to and I hate to use that term, but babies will be offered the breast only once or twice a day, and then the mothers are sent home the rest of the time supplementing, and mothers don't know what to do next. So I think that the goal with for Paula Meyer's, what protocol she's referring to is really looking at, take a 12-hour period and let that baby breastfeed, and then you're looking at that baby's output. And you may be using scales, doing pre and post weights and seeing what that baby takes in. Because we're very regimented. We think that the baby has to eat every 3 hours, and if we do that in a 12-hour period, the baby only gets 4 feedings or 3 feedings. And if they're going to breast on an ad lib basis and mom is staying with them and feeding, and we look at what their output is after 12 hours, we can or we're using the scale, we can see where they're at. And then that can be a guide for how much supplementation they need in the next 12 hours. And that, I feel that can be divvied up. There may be a couple of feedings that the baby has exclusively by bottle, or, maybe the baby's behind by about 4 ounces for the day or something, and you could do 1 ounce at the end of the next 4 feedings to do the catch-up volume that you need. Does that explain it? I hope that explains what they're asking.
Yeah, Chris, if you're still on the line, go ahead and text in if that was good, or if you have other clarifications. So maybe just a really quick one, and we'll make it our last, and we'll double check these and send you any of the Q&As we missed. But I think we're pretty close to catching all the questions. Is just, do you have a most favorite supplement that you use to help increase milk production? I know you said, it isn't, you really do need to focus on the pumping or getting the baby to the breast, but do you have a couple favorites in addition to what you mentioned?
This is kind of a squinchy area, because people are, we're not, people aren't supposed to recommend or suggest. I'm not a prescriber in terms of prescription medications. So there are certainly differing opinions about whether you use a prescription medication like Reglan or domperidone. We don't use a lot of that here, but we do have mothers that do get it. We tend to focus a lot on nutrition, making sure our mothers are getting meals, and increasing the protein. Increasing protein helps increase milk volume, more so even than fluids. But when we talk about supplements, you know, there are some moms that respond really well to fenugreek or More Milk Plus is, you know, there's from Mother Love Herbal. There are definitely different companies that are making these, you know, that are available to them, and that does seem to help for some mothers. But there's side effects or interactions that you should watch for. Recently, we've been using a lot more or recommending Golacta, which is moringa or malungai is a plant. It's more of a nutrition supplement, I feel, than getting into the sort of talking about herbals. And that is currently under study with the World Health Organization, CDC, and looking at many properties in terms of using that for nutritional supplementation for malnutrition around the world. But basically, you're looking at protein and B vitamins and iron and calcium and chlorophyll. All of these sort of nutrition things are very concentrated in that. And I've seen some really good results with moms. And I've even had a mom tell me she just felt so much better on it that I almost wanted to take it myself. So that is one of the things, and you can Google that as well.
Cool.
Great. Well, I think we are going to have to end the questions right now. I think we did manage to get most of them. And again, Kim, thank you so much. It was your expertise on the topic was just fabulous.
Thank you.
Again, this webinar was brought to you by DandleLION Medical, and we are so pleased to have experts like Kim as part of our webinar series. We as a company believe so strongly that all babies should get the best start possible, and obviously breastfeeding is just a key component of that. We also are very big on organic products, and I wanted to let you know that we've just introduced our second organic skincare product, which is Skin to Skin Massage Oil. Newborn skin, and especially premature infant skin, is not fully developed for the first few weeks, and anything you put on a baby's skin is quickly absorbed into the bloodstream. It's important for you as healthcare providers to model safe practices for moms, and these include choosing skincare products that are free from toxic chemicals and fragrance. And if you can find something that's made with organic ingredients, that's even better. Skin to Skin Massage Oil is made from the finest proven ingredients. It's gentle and non-irritating. It's preserved with a natural ingredient, and it really provides a wonderful glide for massage. If you'd like to receive more information about Skin to Skin Massage Oil and would like to get a free sample, you can indicate your interest on the evaluation form. So moving along, in order to receive your free CE, you'll need to fill out the webinar evaluation. In the chat area, Kathy will be putting up the link to the evaluation, or once you're finished, we're finished here, you'll be immediately redirected to the evaluation form if your firewall allows. If it doesn't, or if you're just listening to this as a recording, at the end of the webinar, there will be a link that you will see, or you can get when you do get the recording, there will also be a link to the evaluation again. At the end of the evaluation, you'll receive a link to the CE certificate, and you should download that and keep that for your records. If you are viewing as a group, you must each go and fill out the evaluation separately in order to get the CE. We need to keep our records, so therefore each individual with your license number needs to log on to get that. We hope you'll visit the DandleLION Medical website for future webinars, and we also have links to the recordings of our previous 19 now webinars. This is our 20th webinar. We're very excited about that. All are still active and will contain the continuing education credits. So again, have a great weekend. Thanks again to all of you for listening, and thanks so much to Kim Barbas for another one of our great DandleLION webinars. Bye-bye.